ISA case meet. Good evening, all of you. It's case meet 19 of ISA City Branch Nanded. We are conducting this case meets on the celebration of our Platinum Jubilee celebration year with Silver Jubilee celebration year of ISA Nanded. So we are conducting this weekly case meets. Today's our guest speaker is Dr. Balaji asegaonkar, sir, well known in Marathwada. Everybody knows him. He is a founder member of group practice in Aurangabad. He is a consultant anesthesiologist and palliative care physician at Aurangabad. Ex-associate professor MGM Medical College, Aurangabad. His present affiliation is director of Ozone Anesthesia Group, president of Shesh Sauli Care Center, Sneha Sauli. Geriatric and palliative care center is his main area of interest. Publications till now done till 15 research papers in national and international index journals. Delivered 80 talks in conferences, CMEs. He is an author of a practical approach to ABG analysis. Even conducted 12 workshops on ABG, hemodynamics, and ECMO. Awards and honors, but Proficiency Award at National ISA twice, courses in geriatric medicine and palliative care medicine. Appreciation Award by Geriatric Society of India. So welcome on our ISA Nanded platform.
Should I start?
Yes, sir. Please start.
First of all, good evening to all of you. And I always like Nanded ISA. I have got a very special connection with Nanded because I am born and brought up at Nanded. So whenever I see activities of Nanded, I feel very happy about it. And now President Dr. Prahlad Kotkar, Dynamic Secretary Dr. Sachin, and today's guest, I think Chairperson Dr. Kahekar. Now with your kind permission, I would like to start my topic. Before I start, I would like to request Dr. Sachin Sandolkar, who is the Secretary of Nanded ISA. He is already keeping the record of this, and it should be submitted to State ISA and National ISA, so that I want Nanded ISA should be one of the best, should win the one of best city branch award, state level and national level. And my best wishes are always with Nanded ISA.
Thank you, sir. Thank you.
The topic today, which I'm going to talk about, is perioperative fluid, recent updates. You see that perioperative fluid management, we in day in, day out, we are dealing with this perioperative IV fluids. But still, there is a lot of confusion, confusion among, as a doctor as well as an anesthesiologist, which fluid is to be used in what condition. And we take this topic very lightly. Many times when we are working in operation theater, our IV just get finished, and one of the maybe ward boy or any sister just pick up the whatever fluid she got in the OT and just starts. So there is a very low awareness of specific constituents of different fluid. As such, there is very little formal education and training exist for fluid management. From our MD days, it's been very neglected topic, and just like reassessing the fluid status of the patient repeatedly. These are the very smaller things, but most of the time it is neglected. And nowadays we have got such a wide variety of fluid available to us. It is all increasing our confusion. I am sorry for this slide. But if you just concentrate on left hand of this slide, left part of the slide, if you see the number of saline-based crystalloids, they are almost 4 or 5 normal saline, half normal saline, quarter normal saline, then balanced crystalloids like ringer lactate, isolites, plasmalite, carbilite, normosol. Then dextrose based 6 to 7 fluids are there in DNS, D5, D10, D50. And in colloids, we have got 8 options. So out of these all options, which one has to be chosen, which will be beneficial to be all this seems to be a very complex and neglected subject as far as our perioperative period is concerned. Now, there was a national committee and they done a sort of audit, and what they found that patients are dying as a result of infusion either too much fluid or too little fluid by inexperienced staff. Not only that, fluid is not ever treated as a drug prescription, even though it has got so many complications and so many dynamic effects on our body. So, are you making fluid therapy actually how we take the decision? Actually, fluid therapy should be individualized, understanding the various why we are giving the fluid and what is the goal of our giving fluid to a specific patients. And fluid must be treated as a drug. Similarly, we write a tablet amoxicillin, capsule amoxicillin, 1 TDS. Similarly, specific dose of fluid, specific indication, and specific in how much duration it has to be given. We write 24 hours, give 2 liters of fluid, 2.5 liters of fluid, and we just forget about it. Actually, sister may give this fluid maybe in 12 hours, or for 12 hours she don't give anything, and next 12 hours she infuse all the fluids. And we need to reassess it very routinely, means every after 6 hours, 8 hours, 12 hours, what's the patient situation, and then we have to prescribe the fluid. And whenever you are giving fluid, you must clarify the purpose. We give only for 3 purposes we give fluid. When we want to resuscitate the patient, when we want to give as a replacement, when there is ongoing losses, we want to give fluid, or just for maintenance, when patient is unable to take fluid by oral route or other route, for maintenance purpose, we want to give. So there are 3 important goals for that we want to give fluid. Resuscitation means there is already patient is in shock, or he has already bled somewhere, there is maybe internal bleeding, external bleeding, and now you want to preserve the intravascular volume, you want to restore the tissue perfusion, re-establish the balance between oxygen demand and supply. This is the resuscitation purpose of fluid management. When you want to give fluid for replacement, suppose surgery is going on, there is sudden fluid loss or any thing that is causing loss of fluid, ongoing loss, that replacement purpose of fluid has to be defined. And lastly, it's maintenance, just daily maintenance of water, sodium and potassium. Once you define your goal, then it is very to decide the which fluid is to be selected and how we should approach this topic. So the aim of my presentation is very simple: how to approach this topic, which fluid is to be selected, when to give fluid, and why to give, and how much quantity is. We will try to answer all these questions in next 20 minutes. Now, in preoperative phase, we want patient to be euvolumic. Nowadays, day by day, the NBM period is reducing. Recently, ISA has also published guidelines about Npo Guidelines. And now they are saying that clear fluid should be allowed up to 2 hours before surgery. And complex carbohydrate clear drinks can be allowed up to 4 hours before surgery. Why they are giving such a recommendation? Because any surgery, any anesthesia is stress to the body and causes a catabolic state. But before you face this catabolic phase, you should be on anabolic side. That is why they suggest that if you give some complex carbohydrate, it will reduce the post-op nausea, vomiting, it will reduce the stress hormone secretion, it will reduce the insulin resistance. That is why day by day we are decreasing the NPO period. And even now recently they said one should not be very aggressive in colonic preparation, particularly for abdominal surgery, because it will imbalance the normal body fluid balance. And nowadays there is a concept of rehabilitation. We used to know about rehabilitation. Rehabilitation means something has occurred and now we want to intervene. But rehabilitation means before something happens, we have to do something. That is called as prehabilitation. By all these measures of giving complex carbohydrate drinks before 4 hours, drinking clear fluid between 2 hours, it is kind of prehabilitation. And it is very much useful protocol for ERAS. ERAS means early recovery after surgery. These protocols nowadays, day by day, we want to reduce the morbidity of the patient. Patient should be moving immediately after the surgery. We want to discharge him at the earliest. We are going for a daycare surgery. So all these factors are coming, and that is why these changes are occurring. Now there are two schools of thought. Previously, when I was PG student, whenever there was laparotomy, without thinking anything, we used to give infused fluid, maybe 3 liters, 4 liters, 5 liters. It was a liberal fluid management school of thought. And over a period of time, it has been realized that it has got too many complications. It can cause interstitial edema, it impairs gastrointestinal motility, it causes paralytic ileus, it hampers wound healing, even it is responsible for anastomosis leak, coagulation problem, cardiopulmonary complications, so much. If you are using very liberal amount of fluid without considering the loss, without considering the status of the patient, it has got too many complications. On another side, there was a restrictive. After that, people come out with a restrictive fluid management. They have given a very minimal fluid, and they found that it has definitely reduced the post-operative complications. It is even duration of hospital. A number of papers come out with this. So now, should we follow restrictive or liberal fluid approach? Now, there was a very interesting randomized control trial in New England Journal of Medicine. It is very recent, almost 3-4 years back, 2018. They have studied 3,000 patients for abdominal surgery. And the end point of this study was disability-free survival at 1 year. And they found that there is no difference between the two groups. But they also found that when you restrict fluid too much, acute kidney injury is more common in restrictive group. So which approach we should follow? Nowadays, they are thinking, or rather they advocate zero balance fluid therapy. Means you just keep intake and output more or less same with considering some loss, but don't restrict too much fluid. At the same time, don't give liberal fluid management. Now, how to give this balanced fluid? For that, we used to rely only on our blood pressure, heart rate, urine output, these parameters. But now they say that goal-directed therapy is the best when you are giving the fluid or to the patient. What is this goal-directed therapy? It measures the requirement of patient. This patient requires fluid. That status we want to assess. How you assess this status? By stroke volume variation, by cardiac output monitoring. And this stroke volume variation is nothing but it is on, when patient is on ventilator, due to raised intrathoracic pressure, there will be a changes in stroke volume. Means if these changes are more than 10%, and this is then it is patient can accept the fluid. How you are going to calculate this? There are already monitors for this. This flow track monitor from Edwards. You put arterial line and connect this monitor, and it gives all stroke volume variation, how much is the stroke cardiac output, cardiac index. These monitors we get ready-made. And when you are doing complex cases at tertiary care center, these are the best way you can manage the fluid management. Apart from that, from ABG, indirectly, if there is acidosis, there is electrolyte imbalance, you can guess about the fluid status. Then another important is echocardiography. Nowadays, it is coming in a very big way. Now they say that all OTs should have one echo machine. and it can be used for various purposes. But the important one of the purposes assess the fluid status by IVC filling or IVC distance stability index, and keeping a watch on diuresis. These are, if you follow this, then you can certainly manage fluid in a better. Now, approach to directed therapy is very simple. If there is a stroke volume variation more than 10%, always give fluid. If it is less than 10%, but mean arterial pressure is more than 60, don't do anything. But the stroke volume variation is less than 10% and cardiac mean arterial blood pressure is below 60, you just watch for a cardiac index. If cardiac index is more than 2.5, you add vasopressor, vasoconstrictor, which will increase the afterload. And if it is cardiac index is less than 2.5, means the contracting capacity of the heart is less, you need to add an inotropic. This is a very simple chart of goal-directed therapy, and many centers are following this. And there was a very large trial of optimize trial, means cardiovascular management to improve surgical outcome. It is they compared goal-directed therapy with standard treatment in high-risk patients of undergoing GI surgery. It is 2018 British Journal of Anesthesia. They have produced this trial, and they have clearly shown that there is a reduced incidence of even a post-op infection, duration of hospital stay, and in fact, even the reduce the cost of whole this surgery if you follow this goal-directed therapy. Sir Henry Tizard has quoted, the secret of selecting appropriate resuscitation is fluid is to ask one question: what is the cause and severity of hypovolemia? Now we have, whenever we want to start the fluid, we have got so many, I have already shown you, so many options are in front of us. Now which to choose? So for that matter, we will discuss the advantages, disadvantage of commonly used fluid in our next discussion. Interestingly, I wanted to show you one very interesting diagram. These are the IV fluids used by a country. This is a crystalloid, is shown bluish color, colloid is shown in yellow color, and reddish brown is the blood. If you see the Great Britain, they have used maximum colloid. But if you see the USA, they have used the maximum crystalloid. So from country to country, even from region to region, this use of IV fluid is differing. So what often happens is that patient receives a lot of fluids, it's a lot of sodium, and the commonest fluid used is NS, sodium chloride. And kidney cannot excrete that sodium load. So chloride causes its own complication, and even just giving sodium chloride, we are not giving the potassium, and this depletion of potassium itself reduces ability of kidney to excrete the sodium. So again, it increasing the sodium load over the body. Now, history of normal saline. Why normal saline was called as normal saline? Because it was observed in vitro, in outside the body, it causes less damage to our human red cells. So it was called as isotonic or normal saline. But actually, it is not a very normal saline. And the most common globally dominated fluid used all over the world, maybe in ICU, in OT, is the normal saline. But is it normal, and why it is very commonly used? Another reason is also very inexpensive fluid. Now, if you see the constituents of it, contains sodium and chloride, and see the constituents of plasma. Sodium is more or less just more by maybe 9, but see the chloride. Normal chloride is 98 to 106, and chloride is 154. So very high chloride contents can lead to a hyperchloremic acidosis, which shown to increase the mortality. It it causes acid-based disturbances, renal vasoconstrictions, and just giving normal saline has got its own effect. It has got effect on kidney. It can cause increased arterial pressure on chronic stages. It can cause cardiac hypertrophy, and it produces very oxidative stress on endothelium and endothelium dysfunction. When you give 1 liter of normal saline, 1 bag of normal saline, it's like eating 36 bags of chips. Means 9 gram of sodium we are giving to the patients. That you must remember. So just using normal saline can be a very counterproductive. There are so many trials, meta-analysis, RCTs. What they say, if you only use normal saline, this, and if you compare it with balanced crystallite solution, all time mortality is decreased, renal complication are less, major hemorrhage is less. But on this side, it is balance is totally tilted towards balanced crystallite rather than normal saline. Then there is one study of major complications due to use of normal, they assess, and what they found is there is patients requiring dialysis, acute kidney injury occurring more, almost 5 times common when saline is used compared to a balanced IV fluid. Even in high surgical mortality. Not only that, why we always say normal saline is very cheap, rather that this inexpensiveness has increased its use. But if you see what it is causing, how much resources it is taking, it is increasing the medication use, it is causing more blood transfusion, it causes extra test. If when patient is bad, you are tend to do arterial blood gases, lactic acid levels, then it is increasing the length of hospital stay, it increasing chances of dialysis, even in ventilatory days. So overall, it is causing more expensive than the balanced salt solution. So there is a verdict that implement, and they have shown in many studies that implementing chloride restrictive strategies in tertiary ICU care was associated with significant decrease in acute kidney injury and renal replacement therapy. So the verdict on normal saline is that it increases the mortality, it causes hyperchloremic acidosis, adverse effect on kidney, and the future of IV fluid is balanced crystalloid. 1 liter of, as I already stated, gives enough salt to meet 2 days normal requirement of the body. Now, what about Ringer lactate? Actually, Ringer was an American doctor who added potassium and calcium into the normal saline, and it was called as a Ringer solution. But later on, Hartmann, who is a pediatrician by his profession, he added lactate to this to decrease the metabolic acidosis, and it was called as a Hartmann solution. Now we call it as a more or less Ringer lactate solution. And it contains, if you compare it, see the sodium level, potassium level, calcium level, even lactate, and osmolarity is more or less same. And it is at a very good physiological level, contains bicarbonate to prevent acidosis. And what are the cons? It contains lactate, which requires a good liver, at least normal liver function, to convert it to a bicarbonate. Secondly, it contains some calcium, so you cannot give along with blood or blood products. So possible disadvantage of Ringer lactate, it can cause, it cannot be useful in liver diseases. At the same time, another important indicator we use in ICU is lactate level to see the what's the tissue oxygenation occurring at molecular level. And this lactate level you cannot measure when you give excess of Ringer lactate. These are the possible disadvantage of Ringer lactate. So they have tried to replace this lactate with acetate and gluconate. And why acetate and gluconate is added? Because it don't require hepatic metabolism, and they don't contribute to lactate levels during hepatic, and they can be given in hepatic insufficiency. So buffer has been changed from lactate to acetate and gluconate, and that is how this plasma light solution has come. If you see the constituents of plasma light, it's 140, almost matching our plasma. Then chloride is also normal almost, and acetate, lactate is replaced by acetate. Another advantage is some magnesium is also added to this. So it contains physiological level of sodium, potassium, magnesium supplementation is there, contains bicarbonate precursor. And only thing is that in cases of alcoholic patient, it is not advisable, and it is the most inhibitory factor for its use is expensive. It's bit expensive to use plasma light in our patients. There was series of isolates. We all as anesthesiologists, whenever we get a call from for pediatric patients, before we go, patient was put on isolate P. Isolate P, one of the favorite IV fluid for all pediatric patients. But see what is the content of the isolate. It contains dextrose, it contains lesser concentration of sodium, but see the concentration of potassium. And this, there are different isolates, isolate G, isolate M, isolate E. I will not go in details, and they have got specific indications, and they are being used for a very specific indication. But the most commonly used is isolate P. But see, the normal isolate P contains 20 milliequivalent, and see 10 ml of Kesol also contains 30.4 milliequivalent of potassium. So if you give, this is a maintenance fluid. Many times we continue this fluid in perioperative period, patient is bleeding, and we are giving high dosage of isolate P to a pediatric, but it can be a very disastrous because very high content of potassium, and patient can lead into a cardiac arrest if you give very isolate P or a very small kid or neonate very fast. So one must be very careful when patient is on isolate P. Now, some few slides about colloids. We have got so many colloids available with dextran, hemaxyl, gelofuscin, and starches. And why a colloid is a basically that word meaning is glue. Glue means it does something so that intravascular compartment inside the vascular is maintained. So they have got a higher molecular weight substances. They will cause a volume expansion. They will attract fluid from extracellular compartment to intravascular compartment, so that volume expansion will occur. Now they have got a proteinous or non-proteinous classification. In proteinous classification, gelatin, hemaxyl, these are the bovine. They are prepared from bovine collagens. Albumin, you all know albumin protein colloid. The non-proteinous starches. Starches are hysteryl, pentastarch, tetrastarch, and dextran. Now, there are large-scale randomized trial studies have confirmed that hysteryl causes some toxic effects in ICU patients, and they our choices of fluid has the power to help the patient as well as harm the patient. So we should be very, very careful when we are wanted to choose the patient. This is the overall scenario of various studies occurred as far as hysteryl is concerned, and continuously studies going on. Different kinds of starches are coming nowadays. But overall, what is the verdict that we wanted to find out? There was one study, randomized trial of about 10%, and trial was stopped early for the safety after only 537 because HES was associated with higher rates of acute renal failure, and those patients require renal replacement therapy. Such was the case occurred with HES. Even in septic patients, all these starches has associated with significant higher mortality, significant higher renal replacement therapy. They have used to disrupt coagulation system and cause severe bleeding. There are so many multiple meta-analysis carried out, and all they find that there was using hysteryl or HES was with increased mortality, increased renal replacement therapy. So nowadays we use very minimal. This was a very flash trial. Again, this is a very recent trial. It was trial started in 2015, and the data is published in 2020. They have compared the effect of hydroxyethyl starch versus saline for volume replacement therapy on and the endpoint of death and post-operative complication in high-risk patient undergoing major abdominal surgery. And what is the conclusion? Conclusion was there was no major differences in 14 post-operative complication within 14 days. So why to use such toxic fluid or colloid with so much of expenses? This was the conclusion with this. So the verdict on HACE is side effects are cumulative, it can increase, and there is no clinical as such, not a very clear-cut questionable benefits of HACE. And we all talk about the volume expansion effects of colloid. But in reality, how much is the volume expansion of colloid that offers our crystal? That also been studied extensively. Our conventional belief is that when you give colloid, we replace it as 1:1 for blood loss. And when you replace with crystalloid, we give 3 times more. Suppose there is 300 ml loss of blood, we used to tend to give 900 ml of crystalloid. But for colloid, we give 1:1. But what does the recent literature say? Recent literature is not confirm this finding. On the contrary, there are so many studies, systematic reviews on by Bolt and Lang, and what they have shown, they are only causing 1.4 ratio of crystalloid to colloid is 1 to 1.4 volume expansion. So crystalloids need is more, but the ratio is around only 1 to 1.4, at the most 1.2. So just using colloid for volume expansion is not going to be very useful. This is the recent trend, what it shows. So after so much of discussion, what are our conclusion, or what we want to, what is the take home message if you wanted to ask me IV fluids recommendation? So as far as fluid resuscitation is concerned, benefits of HACE no longer outweighs its risk. So there is no much benefit in using HACE. Only in rare cases where blood is not going to available, we are giving a lot of fluid, which crystalloids, which causing its complication, maybe pulmonary edema, patient is bloated. In that certain situation, you can use HACE, but otherwise also in our practice also, we have reduced its use drastically. When I started cardiac anesthesia, practice of cardiac anesthesia, I used to give HACE for almost all patients, but now I don't remember in last 2 years I have given HACE to any of the patient of cardiac anesthesia. And balanced crystalloids are always preferred over the saline. Then balanced surgical solution should replace normal saline. This is very, very important, except maybe in traumatic brain injury or very specific indications of normal saline. Then always prescribe fluid like a drug with specific indication and dose. Always when you ask yourself question, why I want to give fluid, is it for resuscitation or is it for replacement or is it for maintenance, and accordingly you prescribe or give the fluids. And balanced crystalloid should be the default fluid of choice for all critically ill patients. Now the most important message I would like to give is always assess when you are doing major cases, always assess fluid balance at least every hour. Go to the surgical site, see how much motion, how much is the urine output, and accordingly give fluids. Follow the dictum by default, whichever may be the surgery, but always while shifting the patient, always assess the intraoperative input and output balance, and prescribe, you yourself should prescribe this much fluid is to be given for next 2 hours, 3 hours. As such, surgery is stress to the body, and naturally, due to this surgical stress, anesthesia stress, there will be a increased secretions of stress hormones, vasopressin. And what this vasopressin does, it is an antidiuretic hormone. So it will cause oligouria. This is a natural. So if you want to diuresis, you need to give a small dose of diuretic, what we call is a tickling dose of diuretics, maybe 0.5 milligram of Lasix or Diator, so that you can maintain the urine outcome. In case of positive balance, suppose you feel at the end of surgery patient is too much positive, always give low dose diuretics. And let me tell you, the best way to give fluid is by peroral. Always encourage your surgeon, encourage your surrounding fellow people to shift the patient perorally at the earliest and give fluid maximum by orally. You should keep this chart maybe handy with you. Many times you should, most physiological solutions are ringer lactate and plasma lights. Those rich in sodium are, you all might be knowing, but just keeping this chart handy with you is always helpful. And you can take the help of this chart and decide which fluid is to be given in which patients. Thank you very much. I wish very happy fluid season, for forthcoming fluid season for all of you, in particularly Marathwada region. Thank you very much for inviting me.
Thank you, sir. Very nice talk. New things are covered on this topic. It's a very nice lecture.
Thank you.
Very very good topic. It was not covered till now from ISA Nanded point of view, because we are covering all topics for private practitioner forums, and this one is the very genuine and best topic for private practitioners, and that is covered today. Basically, I want to ask one question before anybody
Yes.
asks. Sir, so many patients we give anesthesia. Before that patient, I asked every patient how many times, वो किती वेळ उपाशी राहिला. He told me around, बाबा मी रात्री 10च्या नंतर काहीच खाल्लं नाही, काही नाही. Almost 12 hours he was not
Fasting.
eaten anything. Total fasting राहतो. And most of the time somebody will eat some drinks or some chai biscuit, something in early morning, if surgeon told him or her that you should take something. But most of the village people, they don't take anything. And once surgeon told him, "Baba रे, तुला उपाशी राहायचे," so he was almost kneel by mouth till the afternoon. Then I go to surgeon. So from that point of view, what fluid should I give first fluid to that patient after giving intracare before spinal? And that procedure also for 45 minutes or 1 hour. What do you think? What should I give him or her?
You can start with ringer lactate.
Okay.
Only thing is, if patient is too much fasted, you should go and do, usually if it is more than 12 hours fasting, and not in obese patient but very thin lean patients where glycogen storage is very less, I would like to do his at least sugar before giving any, starting any fluid. And if it is very low, so you can start with some DNS, maybe 100-200 ml, and then switch to ringer lactate. Otherwise, ringer lactate is the most preferred, that fluid, or plasma light that can be given. But even if you see 12 hours fasting in normal healthy man, won't cause that much of dehydration. Even we ourselves are fasting for 12 hours. It doesn't mean that we are dehydrated. The basic idea of reducing the fasting is to make the, as you are going to face a catabolic state immediately after this fasting, which can be harmful. That is why they advise to reduce this fasting guideline. And they have proven statistically that if you reduce this fasting hours, nausea, vomiting is reducing, that stress levels, stress hormone secretion is reduced, insulin resistance is reduced, wound healing is better, patient psychologically better. Patients say, I'm fasting from last 16 hours. Patient get irritated, and that irritating mood he goes for faces the surgery. So for all these factors, they are reducing day by day this fast, and it is unnecessary to fast patient for more than 6 hours, 8 hours, 10 hours, unless patient is diabetes, unless his delayed gastric emptying time and all that.
So I should start with RL, and then before that I should check the RBS of that patient. Thank you, sir. Our question from today from Dr. Tejas Bhandari. He is our cardiac anesthesiologist from Nanded. He did almost 150 cases in Nanded, open bypass surgeries. He's asking, sir, how much post-op fluid you recommend post-op in between surgery?
Yeah, there is, I don't think anyone can tell this blanket answer to this, but which surgery for how much duration patient is going to remain fast, that will actually give the answer to this question. But roughly, suppose there is a hernia surgery and patient has, we have already given 1.5 liters of fluid, and now for next 4 hours patient is going to remain fast. In that case, I will give 2 ml per kg of IV fluid for next whatever, maybe 4 hours, 6 hours till patient is NBM.
That to be RL or any fluid, whatever. Yeah. Other question from in chat box from Dr. Naseem. As you advised, NBM 2 hour, but in ANC patient, what to do?
Yes, that was a question I was expecting. This what happens particularly in ANC patients and all those patients where there are high chances of delayed gastric emptying time, and even our patients don't many a times they may not be truthful to us. So it is better in high risk patients or in patients there is high chance of aspiration, chances of aspiration are high. In that case, even in my practice also, at least 4 hours NBM I follow for clear fluid, and for non-clear fluid more than 6 hours.
Another question from Dr. Naseem. Sir, as you told, NS increases CL, but in GDM, we use NS. Is it okay?
Sorry, GDM?
Gestational diabetes, I think so.
Yeah. In certain, in ketoacidosis, in gestational diabetes, there is no option to use, still we use NS, even in kidney transplant patient. After post-transplant, we infuse so much of this normal saline to these patients, but at the same time, we are using diuresis to this patient. This patient is throwing urine like 1 liter per hour. So automatically this sodium and all whatever you are infusing, it is getting lost. So in this situation, you have to use it. But the current concept or the current what literature is saying that you should more and more switch to a balanced salt solution. And suppose any fluid you are using, particularly in critical patient, and if you are monitoring the APG, monitoring the electrolytes, you can alter your subsequent line of action. This is very important. Important is monitoring electrolytes. Very, very important when your patient is on IV fluids, when your patient is undergoing major surgery where major fluid shift or major fluid loss is happening. So repeatedly, if you do APGs, electrolytes, then all the line of your further management depends on that reports.
Sir, as you told about hello,
Yes.
as you told about NS, it should not be used excessively,
Yes.
and even you told about RL also. We are the periphery practitioner anesthesiologist. We do mostly D5, DNS or RL. We use these things, and we are conducting only elective cases that to be on half hourly, 1 hourly cases. What do you think? What constituent or single solution we should uh, stick with this? Because due to you told us that NS is not that much favorable for our surgeries. So, according to the fasting of the patients and requirement of the maintenance of the fluids for patients, so which one is the good IV fluid? Should we refer or ask to our sisters or staff to use their these things only other than
No,
yes?
what I wanted to say you that suppose there is a small surgery, means maybe hernia, where there is a minimal fluid loss, or maybe hydrocele, very simple surgery. You have given a
Yes,
spinal.
yes,
Sir, in
yes.
that surgery also people are infusing 2 liters of fluid, 2.5 liters of fluid. That approach is wrong. If it is a ASA grade 1 patient, you just give spinal, you maintain, you even if you use some vasopressor, just there was a why there was a hypotension in spinal, because there is a
Because of
profound
vasodilatation.
peripheral
Yes,
pooling of the
yes,
blood.
yes, yes,
And
yes.
why, how you are treating it? With infusing more and more fluid.
More and more
It is
fluids.
not going to remain in intravascular space for more than 20 minutes.
Yes,
And
yes,
that is
yes.
not the approach. What my point is that just giving IV fluid is not going to serve this. You can give, suppose you are using, you want to save the cost. Nowadays, all the patients are in scheme. Everyone is cost, even hospital want to save the cost. Even in our center,
Yes, yes.
care center also, this plasma light cannot be used extensively. So we are
Yes,
also
sir.
using NS ringer. But the point is that you use it judiciously. You must know these complications, and you should be able to tackle this complication. This is the basic idea. Means practically we talk very ideal situations, but ideal situation never exists in our practice. We, whatever the situation is there, we should know the theory, and we should change ourselves accordingly to deal with the current status, current means whatever status in which we are working. That is the basic idea.
Sir, one of my colleague, I don't want to disclose name, but one of my colleague used to do in our UG days, not now, that he used to do half NS, then after he left that saline aside and then he keep RL, and that was used half. Then after he used D5, and almost OT was a lot of the NS, RL, D5, half salines are there in kept in the OT. And I asked that I asked her him that what are doing like this, भाई half ही देना है तो फिर वो क्या कर रहा है तू, पूरा ओटी पूरा गंदा हो जाएगा, वो ब्रेक करता है सलाइन एंड ऑल दिस. तो वो बोलते हैं नहीं, दिस इज बैलेंस्ड फ्लूइड therapy I'm giving to that patient. What do you say on that, sir?
Yeah, rather than doing that, suppose you are giving only NS to the patient, put one RL in between. Or if you are giving 2-3 RL, just put one NS between. Because alkalosis produced by ringer lactate. Lactate is producing alkalosis, and hyperchloremia is causing acidosis. To some extent, it gets counter. This half, there is no point in giving just 250 ml this and 250 ml and throwing all this. Rather than, I am telling you, try to aim at zero balance. Means not much liberal approach, not very restrictive approach. Always assess output every hourly or at the end of surgery. If you are given a 2 liter of fluid and there is 100 ml output, don't leave patient like that. Just give small dose of diuretic, maybe 5 milligram like 6, twinkling dose of diuretic, and it will ensure that whatever excess fluid is been there, you see many times you go to see the patient on third post-op day in ICU, particularly in pediatric patient, and they are swollen like anything. Why this is happening? Because injudicious use of crystalloids in pediatric patient causing interstitial edema, skin edema, and this is very common finding. You might have seen so many patients to this. So always use, it is a combination of goal directed therapy, combination of diuretic, combination of inotropes, combination of fluids. That is how you should try to manage the patient in a balanced approach.
So in pediatrics, you regularly use to give isolate tea or related to
No,
that?
we use.
Can you highlight on that thing?
You give me the chance, if it is for maintenance purpose, I will always
Yes.
half DNS.
Okay.
Which will means half DNS means sodium load is also less, and pediatric patient requires dextrose, or otherwise, if it is for resuscitation purpose. If it is for resuscitation purpose, you may have to use normal saline or ringer lactate. Nowadays, there is World Health Organization has come out with a very good guidelines 2020, and it is available on net. How much fluid you should give in pediatric patient for first 10 kg 100 ml in next 24 hours, in next 20 kg 50 ml, and next I think after 20 it is 20 ml per kg in 24 hours, and how to give, which fluid is to be selected. They also recommended this NS, RL, but when to give which fluid. These are very small, 8 or 10 pages guidelines they come out with World Health Organization. I recommend all of you, or if you WhatsApp me your number, I can send that guidelines.
Yes, sir. Please send me link, sir. I will share with our group members and all ISM members. Sir, what you means? You are saying that means I want to ask that question. If in pediatric age group, that hernia or small congenital heterosis or something like that, even appendix like procedures, so, and they are NBM for 4 hours as per pediatric guidelines. So for that patient, you recommend for half DNs.
Yeah, routinely in my practice, at least, I usually start with half DNS. I give very minimal fluid, try to maintain his parameters. And at the end of the day, if it is very positive at the end of surgery, I will try to assess again. You have to assess the blood loss, you have to assess urine output, how much, and all these things. And if patient is a bit on more positive aspect, if it is balance or little bit of positive, I will not do anything. But if it is on too much positive, I will give very low dose of diuretic.
Okay. So one of the take-home messages: restrict the fluids and don't use unnecessary fluids, and use inotropes from you I learned today. And all our members also realize these things in day-to-day practices. And this is the really very but I think say this common thing what you said today nowadays we used to anesthesiology. I feel myself as a common anesthesiologist, and we are using almost 1.5 liters fluid for the what we call it spinal reloading or something, loading and reloading. That concept are in our minds in UGs and PGs, and so many conferences they said the reloading is the base part. So you reload the fluid after giving spinal. That was in my mind also. So, but after your thoughts and your talk, I now realize that inotrop should be added with these fluids. And that was the best part for private forum and periphery practicing anesthesiologist.
For my MD days, or in my whenever we used to give spinal, before giving spinal, patient used to be positive by 1 liter. This was a dictum. Unless and until you infuse 1 liter, we don't ever tried spinal also. And even in certain situations, we have to use to give a colloids. But now this preloading concept has not any role or any meaning. Now what they say that it is a co-loading, means you give spinal and simultaneously you load.
Yes.
Don't load too aggressively. If it is already level is high, T4 level, there is a profound vasodilatation, peripheral venous pooling. If you are trying to correct this with fluid, you can correct it. But
Yes.
where this fluid will go when spinal effect wears off?
Yes. I want.
That is the problem. It is going to be in interstitial space.
Yes.
So co-loading, and whenever, don't hesitate to use these inotropes, vasopressors particularly, rather than inotropes. It's a vasopressor. It is why there was a vasodilatation. So use drugs that will cause vasopressing, maybe phenylephrine, maybe mephenteramine, maybe in very high risk patients. And if you are giving spinal anesthesia, we used to connect with noradrenaline drip, low dose noradrenaline. This is very useful. You can avoid spinal hypotension to these patients.
Okay. So overloading of fluid with imbalance of electrolyte.
Preferably balanced fluid.
Yes.
Small case, it won't affect. Means young patient, very small pace. You should also try to ideally balance salt solution, but they are costly. They are almost 5 times costly than what normal saline or RL is costing. So if you also want to, this won't affect too much in very small cases. This is useful for major cases, major abdominal resection, anastomosis, all these where 4-5 hours abdominal surgeries are going on, Whipple surgery, where definitely there will be changes on ABG, changes on electrolyte, changes on pulmonary capillary, patient may land in pulmonary edema, decreased oxygenation, all have got again negative effects on kidney perfusion, where you need to be very cautious in fluid management.
Nowadays, what I do, I'm speaking frankly now, that after giving section for section, I go for that case, and as you said, I start co-loading after giving spinal simultaneously. Just now, I giving intracath after that patient was spinal दिलं आणि बस झोपवले सुरू केलं आपलं fluid. And for pitocin and other purposes, I have to push my fluid fast. And before the surgery complete, I pushed almost 3 points. That was almost 1.5 liter. आपण म्हणू शकतो 1.5 liter मध्ये infuse करून टाकलं पेशंटला. In section patient, already fluid overload is the concern on pediatric. Basically, pregnant patient is already over volume patient, overload, and we are infusing 1.5 liter in that patient. What do you say on that, sir?
Giving 1.5 liter is our normal phenomena for spinal patient, but you should at the end of surgery reassess how much is the urine output, how is the color of the urine, and if you feel patient has been overloaded, then you give low dose of diuretic. That fluid will automatically. These all are young patients. Their kidney is normal.
Yes.
Small dose of diuretic, their fluid
should
balance
be given.
Normalized.
Should be given.
I very routinely used this diuretic in my practice, and it's for balance. My target is balance at the end of surgery. My whatever fluid I have given and whatever output I am expecting, maybe in next 2-3 hours, it should get balanced. Particularly crystalloids when you are using.
What crystalloids you use in your daily practice?
Pardon?
For this case, for what crystalloids you use in your daily practice?
Most of the time I use ringer, and sometimes for major abdominal surgery and all this, we can I use this balanced means plasma light and all that.
AC1 patients, you use a ringer lactate or like that solutions, but for geriatric or pediatric patients, the class of patient is different. With cardiac cases, you use different solutions. Yes. So can you elaborate on that?
Yes, patient with special indications, which severely means octogenarian or geriatric patients whose fluid requirement is less, whose intravascular compartment is too much compromised, where we have to use the fluids very judiciously. So I won't use the fluid very fast, and particularly crystalloids, that is like normal saline, because they have got a precipitous effect if there are side effects of this fluid is happening. Maybe fluid overload, maybe hyperchloremic acidosis. So I will be very judicious in using fluids, particularly in geriatric fluids. Suppose artho case is there, I will be very aggressive in keeping the level of spinal anesthesia below umbilicus. First of all that, so that requirement of fluid, requirement of everything will be reduced. then I will use fluids very judiciously, maybe ringer lactate, or maybe suppose this patient is very thin lean, his glycogen storage is less, might use DNS. And if a patient, this surgery lasts for too much long, then I may switch third or fourth point, maybe a plasma light. This is how I practice.
Thank you, sir. Thanks a lot. I think I asked more questions than audience.
No
On my
problem.
personal.
It was interesting.
Sir, from Dr. Naseem, low dose of NORAD. Please
Yes,
explain in detail.
let me tell you, I have done, the dictum is you should not give spinal anesthesia, particularly to a cardiac cases who has got a ejection fraction less than 25%. And suppose this patient comes for a tibia fracture. Now he may be a geriatric patient, his lungs are not good, his baseline saturation. Now, if you consider pros and cons, I will give spinal anesthesia to this patient with central line, with low dose non-adrenaline drip on board. Because whatever the precipitous hypotension or peripheral pooling going to occur with this low dose spinal anesthesia, this I wanted to prevent. And what dose I am using? 0.01 microgram per kg per minute. Very small dose, maybe, or 2. If I start with 2 ml means 0.02 microgram. This is just dose which will avoid excess of vasodilatation, which will maintain his mean arterial pressure. For all anesthesia, our target is as balanced fluid intravascular compartment and mean arterial pressure above, particularly in geriatric patient, above 70, above 65. Because even a 10 minutes of hypotension can cause acute kidney injury to this patient. So we should be very aggressive. And for that matter, I routinely use this technique of low dose noradrenaline in this patient.
Sir, other question is diuretic is contraindicated in PIH patient. What to do? From
Yes,
Dr.
in
Naseem.
PIH patient, what's happening is due to increased vasoconstriction, there occurs already due to severe vasoconstriction, intravascular compartment is very much compromised. Now, in PIH case, you are remove the cause, you are delivering the patient, and you are removing the cause why this PIH is occurring, and you infuse the bit more amount of fluid, because there will be a profound vasodilatation as soon as you give the spinal anesthesia. You have to use the fluid in this patient. Once you fill the patient adequately and still patient is not throwing urine, patient is oligouric, at that time you can give diuretic. But initially, of course, diuretics are not to be given in PIH patient.
So many questions are coming now. Last question from Dr. Naseem, I think. So low dose diuretic, please explain in detail.
Yes, low dose diuretic, as I already told in my presentation also, what we call as twinkling dose of diuretic. Twinkling means Marathi bolone. Just we want to call urine to come out. As I already stated, this surgery is stress and it causes secretion of increased levels of vasopressin. That is anti-diuretic hormone. That is why patient is become a oligouric, or there is a decreased urine output. And in this situation, if urine is not coming due to this hormone, and you just wanted to kickstart that urine, so you give a small dose of diuretic and urine will start. And I have seen a wonderful result. You just give 5 milligram of diuretics and see the results. The patient start 200 ml of urine in next 1 hour. So very means this concept I like very much.
Sir, other questions from our famous cardiac anesthesiologist Tejas is asking, sir, how do you calculate third space loss in a dictum with respect to different kind of surgery?
Yes, third space loss naturally means, suppose it has got two meaning. Firstly, suppose there is a patient of liver failure or patient of pleural effusion in preoperative phase, then you can means arbitrarily, not it's a very perfect judgment, but it depends upon the amount of ascites, amount of pleural effusion fluid you can first you can predict. Secondly, suppose this you open abdominal, it is open for more than 2 hours, 3 hours, everything is exposed. And in this case, you just, it is, I don't think there is any specific way you can calculate. You just arbitrarily assume that there will be a third phase loss, like maybe 5 to 10 ml per kg per hour, and that much loss you have to replace.
Sir, other question from same Dr. Tejas Bhandari. Sir, I beg to differ regarding diuretic use because even small amount of diuretic trigger urine output and so face problem of hypokalemia.
Yeah, hypokalemia can occur. So, sorry, I didn't get it. What
Should
is
I?
it?
Should I? Okay, sir. 1 minute, sir. He's asking, sir, I beg to differ
Yes.
regarding diuretic use because even small amount of diuretics trigger urine output, so face problem of hypokalemia.
Achha. But if you
So
don't, yeah,
yes.
I have in one of my slide also shown, if you don't
Yes,
give
sir.
and if you infuse the sodium, and
Yes.
only giving sodium itself causes decrease, and if you don't give potassium, retention of sodium precipitation, it can cause hypernatremia. So you have to excrete this sodium by one way. You have to excrete that fluid which is going to interstitial space. I'm talking about why interstitial loss of fluid in interstitial space. I wanted to avoid that. That is why I want to give diuretics. And you can use rather than if you are so much careful about potassium level, you can potassium sparing diuretic like torsemide you can use.
Yeah. So
But small amount of, and if they you can keep a watch, unless and until more than 1 liter or 1.5 liters of diuresis occurs, there won't be a much problem of hypokalemia.
I think all questions are answered. Dr. Deepak is asking, means he is commenting on open abdomen third space loss is calculated as 500 ml per hour.
Yes, what
Yeah,
am I
I
saying?
think so.
10 ml per kg,
Yes.
roughly hours. Means
Same. It's
50 to
same,
60 means
same.
500
Yes.
ml.
It's very fruitful and very knowledgeable talk and topic also, and speaker also same on that, because you are working on that field. You are a geriatric person, you work on that because of your Sneha Sauli, you really work on that, and even you are cardiac anesthesiologist. So both things are important for us. From cardiac point of view, we should know how much fluid is overloaded on heart, and from geriatric person point of view also, how much fluid he should not take regularली or should not take. So really sir, तुमचा हा टॉपिक खरंच छान एकदम म्हणजे सगळीकडनं अँगलने आम्ही बऱ्यापैकी नॉलेजेबल होता. And I'll take permission from our panelist, Dr. G.M. Kalekar sir. He is our senior member from ISA Nanded. He was sir. Please तुमचे 2 शब्द या याच्यावर.
Yes.
तुम्ही एकतर या अनुषंगाने तुमची भेट झाली आणि बऱ्याच दिवसानंतर तुम्हाला भेटलो मी. एक पीडियाट्रिकचा कॉल होता आणि सरांनी मला बोलवलं होतं की अरे सचिन तू ये. सरांनी जस्ट सरांमुळे मला पाहायला भेटलं की हाऊ टू इंड्यूस अ केस इन पीडियाट्रिक्स, आणि त्यातल्या त्यात युरोलॉजीची केस होती. फार सुंदर केस झाली ती, आणि त्यानंतर आजच भेटतोय मी सरांना असं मला वाटतं.
We are extremely grateful to you, Asegaonkar sir, for the elaborate and lucid presentation highlighting practical aspects. Thank you, sir.
Thank you, sir. I really enjoyed this talk and very eager to personally meet all of you. Thank you very much.
Yes, thank you.
Good
Thanks. So I conclude this session. Thank you all of you dignitaries, Dr. Kalekar sir, our guest of honor, and our speaker, Dr. Balaji Asegaonkar, sir. Thank you.